I've been given about 15 minutes to cover the topic which is titled as limb salvage in osteogenic sarcoma. I'll try my level best to finish in time so that we can have a fruitful discussion over the cases later on. A few basics. We know that osteosarcoma is one of the most common primary malignant tumors of the bone. So many of us are going to encounter a case of osteosarcoma sooner or later in our practice. These are the cells which actually the neoplastic cells which produce osteoid matrix directly and is typically found in more in males, tends to affect the metaphysis more than the diaphysis with a ratio of 90% to 10%. The estimated incidence in India is supposed to be somewhere between 2 to 3 million, 2 to 3 cases per million per year. So that's about 3,000 cases in India, within India itself per year. We have a bimodal distribution, meaning by we see cases which are in their late teens, around 15 to 20 years of age. And then we have a second peak of osteosarcoma, which we see in the 5th decade of the patient's life. It can affect any part of the body, any bone in the body, but commonly seen in around the knee joint, in the proximal femur, in the diaphyseal area, in long bones such as the femur. We know that radiologically there can be various appearances. It can be purely lytic, it can be purely sclerotic, or it can have a mixed lytic and sclerotic appearance. One of the most important investigations that we rely on as far as the local staging is concerned in osteosarcomas is an MRI scan, which we sort of prefer to get a contrast enhanced MRI so that we can have multiple information such as the exact intramedullary extent of the tumor, the extraosseous extent of the tumor, whether there are any skip lesions in the bone when we scan the entire bone, including the distal and the proximal joint. We get to know what is the status of the surrounding muscles, what is the proximity of the neurovascular bundles, and so on and so forth. So there's a lot of information that we get to know from the MRI scans, which we also use to plan our biopsy. X-ray chest is able to show us metastasis only when the metastatic pulmonary nodules are more than 2 centimeters in size. And the distant staging investigations basically of choice currently are a CT scan, a plain CT scan of the chest with thin slices, which can show us nodules as less as a few millimeters in size. And the other skeletal staging investigation is a 3-phase bone scan, as compared to a PET scan, which is one of the latest investigations. The problem with the PET scan currently is the specificity. The PET scans do lack the specificity. They don't show an FDG uptake in lesions less than 1 centimeters in size, and that is where the problems start coming in. So for distant staging osteosarcoma, we still prefer a plain CT scan of the chest along with a 3-phase bone scan. Once we have done the local and the distant staging in a suspected case of an osteosarcoma, we start treating the patient only after we have a histopathological diagnosis, after we have performed a biopsy. Just to give you a short idea of how you should be doing the biopsy, it should be the shortest route to the tumor. We should be violating only one compartment as we approach the lesion. We should remain away from the joint and remain away from the neurovascular bundle. Try to avoid any joint contamination, and more importantly, stay in line with the proposed incision for the final limb salvage surgery, because this particular biopsy tract we consider to be contaminated and we remove at the time of final resection of the tumor. Well, how are we treating these particular osteosarcomas currently? Chemotherapy was introduced only in the late 80s and early 90s in India. Before that, most of our osteosarcoma patients used to present late, end up having an amputation. Eventually, they would have metastasis, and eventually almost all of them, maybe less than 10% would survive, more than 90% of them would die. But in the late 80s and early 90s, we started getting access to good chemotherapeutic agents. We understood the principles of limb salvage better. We had good quality implants available, and also the expertise and infrastructure started improving within India. So nowadays, what we are looking at is the diagnosing the patient early, treat them with neoadjuvant chemotherapy, operate them, resect the osteosarcoma in the extremity by doing the limb salvage surgery. And in almost 50% of our patients, we are now able to achieve a cure. That is, the patients are totally cured of the disease on a long-term basis. So when we are talking about a limb salvage in a high-grade sarcoma, the question that we face most of the times is that will it not compromise on the overall survival and the local recurrence rate in these particular patients? And this particular question has been safely answered by a lot of studies and papers that came out in the late 80s and early 90s again, and which showed that if you do the surgery properly and if you give adequate chemotherapy, there is no statistically difference in the rates of local recurrence as well as overall survival in the patients of osteosarcomas. And that is what emboldened us, and we started doing more and more limb salvage surgeries, to the tune that most of our surgeries now, to the tune of about 95%, are limb salvage surgeries, and less than 5% are actually amputations. Osteosarcoma is one of the lesions where we would definitely treat the patient using neoadjuvant as well as adjuvant chemotherapy. Initially, this was started so that we could get some time for manufacturing the customized endoprosthesis. But now the endoprostheses are available off the shelf. We don't have to really wait for them to be manufactured. But as we were waiting, we found out there are a lot of other advantages of giving the neoadjuvant chemotherapy. The surgery would be easier, the extraosseous tumor component would shrink, the vascularity will be lesser, the satellite lesions in the reactive zone around the tumor would be sterilized. And obviously, once we resect the lesion and send it across to our pathologists, they will be able to give us the evaluation of the chemotherapy response, which will decide the prognosis of the patient. In osteosarcomas, what we do is we treat the patients with wide resection. We used to do a radical resection beforehand, but we have stopped doing it now. Intralesional resections or marginal resections are a strict no-no in osteosarcomas. So what do we mean by a wide excision? When we resect the bone, we have to be at least 3 centimeters away from the intramedullary extent of the tumor. If you have an extraosseous soft tissue component of the lesion, then we have to keep a healthy muscle margin on the soft tissue mass. And we prefer to have a natural barrier like the joint cartilage or the physis or the cortex, if we can, so as to improve our margins, because now the quality of the margins is equally important to the quantity of the margins. As far as the neurovascular bundle is concerned, we can just leave the fascia of the neurovascular bundle onto the tumor if it is really very close, and that itself amounts to about a centimeter or centimeter and a half of margin if you want to convert that into a quantitative margin. Well, who are the patients whom we select to do a limb salvage? There are many multiple factors that decide that. First and foremost is that whether the patient has got any metastasis or not, because if the patient has presented with metastasis, it means a poor prognosis for the patient. We have to assess the salvageability, about which I'll be speaking in the next slide. And obviously, in cases and in patients like ours in India, we have to think and give a lot of importance to the socioeconomic status of the patient as well, as to what we are going to do for that particular patient and family. So who's an ideal candidate for limb salvage? It's that patient where we are able to achieve a good margin. We are going to be able to resect the tumor completely, and we are going to be able to leave behind adequate muscle in the limb so that it can give a good function to the adjoining joint. And obviously, this patient is now expected to complete the chemotherapy and the entire treatment later on. So it's a fine balance that needs to be achieved between saving the function in the extremity and controlling the disease. But one has to remember that under no circumstances, the disease control can be compromised so as to save the function. There are always patients that are going to present to us late. One can try to be godly, but we cannot be gods. So in such type of tumors, we have to be realistic in setting goals. And these are not the ideal limb salvage candidates. These have to be treated by an amputation. If we want to talk about the absolute barriers to limb salvage surgery in osteosarcomas, there are actually only two. One is where there is an encasement of a major motor nerve in the extremity. And number two is if you are not able to leave behind adequate muscles after resection, which can give an adequate and stable function in the adjoining joint. So these are the only absolute contraindications. Everything else, like infection, badly placed biopsy scars, or presence of a pathological fracture, all these are now considered as relative contraindications. So typically when we resect the tumor, there is a large defect, as you can see in the picture, that is left behind. And this particular defect has to be reconstructed. The reconstruction is expected to be stable, mobile, and durable, so as to give the maximum functional outcome to the patient. And there are various methodologies by which we can do this reconstruction. It could be an customized endoprosthesis, or it could be a modular endoprosthesis. It could be arthrodesis, it could be a rotation plasty, or it could be an extracorporeal radiotherapy reimplantation. And we are going to see an example of each and every case in the next few slides. So this particular reconstruction option is decided as per the patient's age, the site of affection, the demands of the family and the patient, and the expertise and the infrastructure that is available at our centers, and obviously the finances that are available to the patient. Mega processes is the most commonly used reconstructive modality. There are various options, both indigenously manufactured and the imported ones. And that's a case of a distal femur osteosarcoma that has been resected with good margins. And reconstruction has been done by using an indigenously manufactured endoprosthesis. And you can see that these patients are able to have a 90 degrees knee ROM with good extension, no extension lag, and they have an excellent gait as well. So typically these particular patients, you cannot even make out which leg has been operated. Proximal tibia, likewise, osteosarcoma has been resected, reconstructed using a mega prosthesis. And here as well, you can see that barring there's a little thinning of that particular limb, the patient has an excellent functional outcome. If the disease is intra-articular in the knee, we can do what we call as an extra-articular resection, whereby we take out the lesion completely with the joint and do a composite type of a mega prosthesis, where again it's a safe margin, oncologically safe margin, and the patients can have an adequate function. Proximal humerus is again another common site where osteosarcomas can be seen, and here again the principles are the same. The problem here is since we have to resect the rotator cuff muscles and the axillary nerve, because most of our tumors will have an extraosseous spread in the proximal humerus, the patients typically don't have a good shoulder function. What they have is an excellent function in the elbow and the hand, as you can see in this particular girl, but they lose their shoulder function. But we have to remember and tell the patient that this has to be compared with an shoulder disarticulation, which she would have otherwise ended with, and not the normal contralateral extremity. Sometimes we do get patients where an sarcoma has been inadvertently fixed in the form of an intramedullary nail. So this was a case where then we had to go in after giving him neoadjuvant chemotherapy, resect the entire femur and do what we call as a total femur replacement. So a total humerus or a total femur replacement, depending upon the disease extent or whether an intervention has been done inadvertently earlier or not, can also be done. A similar type of a processes can be used for a proximal femur osteosarcoma as well. What about diaphyseal osteosarcomas? These are a few examples which we have treated in various manners. That's a mid-femur diaphyseal osteosarcoma, which has been resected. This is called as an intercalary resection, where we have used a vascularized fibula for reconstruction and a long plate. And you can see that over the time, the fibula has beautifully hypertrophied, and the patient has got an excellent functional outcome. He is able to do his full knee ROM, to all his heavy activities of daily living, and absolutely has no functional deficit. There are other ways of doing the reconstruction. That's a very young boy and sarcoma in the mid tibia. And here what we have done is that resected the intercalary part. We have done a joint, growth plate, epiphyseal plate sparing resection, done an extracorporeal radiotherapy reimplantation. And you can see that that particular graft has united well. The radiated bone has united well with the host bone, and in fact in the follow-up x-rays you can see that both the growth plates are growing in length as well, proximally as well as distally, and the patient has got an adequately good function. There are other means. If you have got the expertise available, we can do a combination of extracorporeal radiotherapy and a vascularized fibula, which is combined together. That probably gives the best functional outcome, and that's the patient of a mid-femur osteosarcoma who has been treated in this particular fashion. And you can see that vascularized fibula and the allograft have both beautifully united with the host bone, and the patient has had an excellent functional outcome. Pathological fractures, as I mentioned earlier, is not a strict contraindication to limb salvage surgery. This particular patient was treated with chemotherapy and then reconstructed using an intercalary mega prosthesis, as you can see in this particular slide. Pelvis is another site, though not very common, where you get to see osteosarcomas. They are not very rare as well, and these are the cases which are again treated in a similar fashion, treated in the form of internal hemipelvectomy, and various types of reconstructive modalities can be done. This particular case, an ischiofemoral arthrodesis has been done. But currently, our favorite methodology is doing something as what we call as a mesh plasty. We just resect the tumor, use a Prolin mesh to sort of create a pseudo joint, and the patient has an excellent functional outcome in these particular cases. As you can see that there is hardly any limb and abductor lurch, and even though the entire hemipelvis is missing, he is able to walk on that particular extremity. Children less than 10 years or 8 years are a particular age group because of their small bone sizes, because they keep on growing and they would have a limb length discrepancy. The option of mega processes is going to be extremely costly because these are the expandable mega processes, either the invasive ones or the non-invasive ones, which are expanded by using a magnetic coil and a magnetic mechanism. But these are prohibitively expensive. So what we prefer to do in children less than 8 years of old with osteosarcomas is the procedure called as a rotation plasty, wherein we resect the tumor, shorten the extremity, rotate it externally 180 degrees, and allow the ankle to substitute for the knee. The advantage is that the children adapt to this particular procedure really very well. They don't feel as if they are walking on they feel as if they are walking on a natural limb. They have a knee control, and psychologically, it's a much better outcome. This particular patient has just been fitted with the prosthesis, and though he has a limb right now with adequate muscle strengthening, his gait will be much better later on. All these particular cases that I've shown you are fantastic to know the results, to see the results, but there can be a lot of complications, both intra-op, early post-op. There could be implant-related complications, and there could be disease-related complications like local recurrence and distant metastasis. And the person who's going to treat this particular patient has to know how to pick up these complications early and how to deal with these complications so as to maintain the adequately achieved functional outcome in these particular cases. One has to note that almost 50% of these particular cases will require revision surgeries. Average 3 to 4 surgeries are required in the patient's lifetime, eventually later on. And in almost 50% of these patients undergoing repeat surgeries, the final functional outcome may be same or worse than an amputation. So we need to select our patients very carefully. One has to remember that if we select the cases well, if we have good surgical skill and experience, if we plan well, make use of the improved technology, and make use of the advances in adjuvant modalities, limb salvage is still possible in majority of our osteosarcomas, though they are extra compartmental. I thank you very much for your patient listening and for inviting me and giving me this opportunity.